Hello everyone, my name is Dr. Meenal Garg and I am a gynecologist and a laparoscopic surgeon from Meerut. And today we are going to discuss a case of a young girl who had a unicornuate uterus with a functional rudimentary horn. She came to me at the age of 12 years and she had attained menarche at the age of 11 years, some 8 months back. Initial 1 or 2 cycles were okay, and then she started having severe dysmenorrhea during her periods. Initially, she was given painkillers, 1 or 2 months they worked, and then they stopped working after 3 months. And now, by the time she presented to me, she was having severe dysmenorrhea and she had continuous pain in her right lower abdomen for past 20 days. On examination, the vitals were height 132 centimeters, 28 kgs weight, vitals were normal. And on per abdominal examination, she had tenderness on deep palpation in the right iliac fossa. On local examination, there was nothing abnormal to find any abnormality. No abnormality was found. She had also been prescribed continuous OCPs by some gynecologists, but they had not given it a thought. And they had taken only NSAIDs till then. I asked for an ultrasound, and ultrasound finding, when it was done, it showed a uterus with two horns, and they had given it query bicornuate. One horn showed internal echoes with no vascularity on color Doppler, and query there was a presence of hematosalpinx. To confirm the findings, further there was one MRI asked, and the MRI again confirmed a doubt, and they also showed the possibility of bicornuate uterus with non-communicating right horn with right hematometra and right hematosalpinx. Then patient on the presumptive diagnosis of not bicornuate but yes in unicornuate uterus with rudimentary horn, we proceeded ahead for laparoscopic excision of that mass. So a vaginoscopy was done because she was a very young girl after taking informed consent, and there was a presence of unicornuate uterus with the cavity. A laparoscopy was done with three ports, 10 mm infraumbilical port and two 5 mm side ports on the right side. And this is what we found when we entered inside. There was this mass which we are now trying to separate from the sedations, which was the accessory rudimentary horn. And it was having the mild hydrosalpinx. So the tube was excised. The femoral part of the hematosalpinx was also excised. Here you can see one thing, that because the patient had presented very early, so the mass did not get much time to become very large. This is very important. It is very important to take decisions at the right time. Like when some girl is having dysmenorrhea, it's completely fine that we give her a course of NSAIDs or OCPs for 3 to 4 cycles. But if somehow the medical management is not working for 2 to 3 cycles at a stretch and the pain continues, then definitely we have to look at our basket again. Now, because there can be anomalies in the renal tract, though we had done the ultrasound KUV and it was showing normal findings, we are just opening the peritoneum and confirming the presence of the ureter so that we don't inadvertently injure it. And after confirming the presence of the ureter in the correct location, then we will proceed further ahead. These patients can have around 30% chances of having a unilateral renal agenesis along with. So, whenever we encounter any Mullerian anomaly patients, especially with unilateral abnormalities, it is very, very important to go for ultrasound KOB and confirm that this, yes, the renal tract is normal. Now, what is the embryological basis of this kind of defect? Look, there are two Mullerian ducts. So, whenever there is one Mullerian duct which is developing normally, and the other Mullerian duct, it does not elongate and couple with the urogenital sinus, which forms the lower one third of the vagina, we can have these kind of abnormalities. So here we can see we are excising the rudimentary horn, and it was not totally attached to the normal uterus. At times, you have to literally give incision on the lateral wall of the normal uterus to excise it, but here it was connected with a band, and we have confirmed that it is not attached to the bladder, so there was no need of deflecting the urovaginal fold of peritoneum. The mass was excised completely, and now we are giving cuts on this with cold scissors, and we are going to find a very tiny small cavity with the functional endometrium and yes, some amount of hematometra along with. So this confirms our diagnosis that it was a unicornuate uterus with a functional rudimentary horn which was not communicating. If the case would have been neglected, then this mass would have become very large. Many of these patients get diagnosed in the third decade of their life when they just cannot bear the dysmenorrhea anymore, and especially most of the females get worked up only when they suffer from infertility. Now, the normal uterus is being anchored with the right side round ligament to maintain the normal anatomy. We can see the right ovary is normal, there is no endometriosis. And apart from this, some adhesions which were there in the rudimentary horn, there was no evidence of very obvious endometriosis in the patient, probably because of the timely diagnosis. Had the case been neglected, we could have find very different findings in this patient with large mass, large hematosalpinx. Many of the cases do come with endometriosis also. Now the mass is being taken out with the help of oscillator, and it really gives me a very good feeling when I see this patient going to school normally without having to take a break because of severe dysmenorrhea. I really love her smiling face. This is the classification. It has been described in AFS classification, the SG classification, and the recent ASRM classification, where it is not a bicornuate but a unicornuate uterus with rudimentary horn with functional endometrium. Thank you.